Hi guys, and welcome back to my channel. If you're new here, I'm Lani. I'm a first year medical student in Australia, and we are using mind maps to cover a range of topics from different disease mechanisms to different processes in the body. So remember, if you have any topics that you would like covered in a mind map, please put a comment down below or follow me on Instagram and DM me over there. So without any further ado, today's mind map is going to cover pathologies of the liver that are associated with chronic hep C. So, starting off, we have our hepatitis C, our HCV in short, and we know it's one of the most common causes of cirrhosis in the developed world. So it's a non-cytopathic virus, and we have the CD81 molecule on the host cell surfaces that will act as a viral receptor that then allow for endocytosis to occur. So once the virus is within the hepatocyte, we have this whole mechanism occurring for it to then reproduce, and then finally we end up with the positive strands being packaged with core and envelope glycoprotein into mature virions, and then they exit via exocytosis. So this core, as you will see, is going to play a really important role in the pathogenesis of many of the pathologies that we are looking at. So first of all, we will be looking at how hepatitis C is going to cause fatty liver disease or hepatic steatosis. So there's three types that we can get, three types of routes, so to speak. So first of all, we have the genotype 1b, which is mostly responsible for virus interference. And this is where the HCV core protein in the intracellular post-receptorial pathways of insulin, it interferes in those pathways, and it's often called VASH. So what it does, it promotes that type 2 diabetes mellitus and the lipid metabolism derangement, and then of course leading to hepatic steatosis in the end. The second type is where it's virus triggered. So the virus itself is almost toxic, you can say. But even though this is usually strictly linked to the HCV genotype 3 infection, some of the other HCV genotypes can still cause it or make it more prominent. So it's also to do with the intrahepatic viral load that we see with the HCV3 genotype. The reason that they link it to the HCV3 genotype is because we can see a resolution of the steatosis in most of the patients that's infected once they've had the HCV eradication antiviral therapy. Now, how does it do it? There's three ways that the virus itself triggers fat storage in the liver. So first of all, we have impaired assembly and secretion of the lipids from the hepatocytes, especially your VLDL. The second way is where we have increased de novo synthesis of your free fatty acids, particularly the HCV core protein activates and it aids in the cellular lipid synthesis. The third way is where we have impaired fatty acid degradation. And the way it does this is we have the HCV core protein that downregulate the peroxisome proliferation activated receptor alpha. And this is the receptor that's involved in your fatty acid degradation. And it also downregulates the mitochondria beta oxidation. And this causes a decrease in the actual clearance of the fatty acids from the liver. The third type of way is where the host factors play a vital role in the whole pathogenesis. So if a person already has metabolic syndrome and visceral obesity, it would make them more susceptible to this because we already have this condition of insulin resistance. So your insulin resistance promotes your lipid accumulation, inflammation, and fibrosis deposition in the liver with disease progression. So your elevated insulin levels and insulin resistance promote that continuous synthesis of triglycerides in the liver. And so all three of these ways are going to bring us to the hepatic steatosis or fatty liver disease. So your fatty liver disease, or NAFLD in this case, because it's non-alcoholic fatty liver disease, is classified as the presence of macrovesicular changes without inflammation or steatosis and lobular inflammation in the absence of significant alcohol use. And we need an intrahepatic triacylglycerol of at least 5% of the liver weight for it to be classed as an NAFLD. So what kind of complications do we expect to see in this condition? Because we have this lipid accumulation in the non-adipose tissue, we see this progression of insulin resistance. And then, of course, the onset of diabetes mellitus and cardiovascular disease consequentially. We also see cirrhosis, ascites, esophageal varices, liver failure, liver cancer, and type 2 diabetes. So you'll see there's a whole link between these conditions. But coming back to our NAFLD, we have two subgroups. So we have the NAFL, which is the non-alcoholic fatty liver, and then we have the NASH, which is the non-alcoholic steatohepatitis. The thing is, this is a continuum. So we start off with the non-alcoholic fatty liver. So that's the more mild form. And it's defined as the presence of hepatic steatosis with no evidence of hepatocellular injury. So we don't see any ballooning of the hepatocytes. But as we progress through the spectrum, we end up with NASH. So this is defined as the presence of hepatic steatosis and inflammation with hepatocyte injury. So we can see this ballooning. We also have Mallory-Hyaline and mixed lymphocytic and neutrophilic inflammatory infiltrate in the perivenular areas with or without fibrosis. So that's the definitions of these two subgroups. So as we get prolonged hepatic lipid storage, we see more dysfunction, more inflammation, and we end up with this chronic liver injury over time that will lead to the activation of the stellate cells, and then this creates a potential for hepatic fibrosis. So the second way that hepatitis C affects the liver is causing liver cirrhosis, and the way it does it involves multiple cells. So we have the hepatocytes and the sinusoidal lining cells, such as the hepatic stellate cells or HSCs. We have the sinusoidal endothelial cells, the SECs, and the Kupffer cells, KCs, which all play a role. So our KCs are satellite macrophages that line the wall of the sinusoids, and studies, especially in animal studies, it has shown that it plays a role in liver fibrosis by releasing harmful mediators when it is exposed to that injurious agents, and then it acts as an antigen presenting cells for the viruses. The second cell, the hepatocytes, when they are damaged, they release reactive oxygen species and inflammatory mediators again, and that can also promote activating our HSCs and liver fibrosis to follow. Our HSCs, they also form part of the wall of the liver sinusoids, and they function to store vitamin A amongst other functions. So when these cells are exposed to inflammatory cytokines, so remember we've got these inflammatory cytokines released from these cells. So when they are exposed to these inflammatory cytokines, they get activated and then they transform into myofibroblasts, and then they start to deposit collagen, which then results in fibrosis. Now the thing is, a characteristic of the cirrhosis that is caused by Hep B, C, alpha-1 antitrypsin deficiency, and primary biliary cholangitis is a macronodular cirrhosis, and this means it's irregular nodules with a variation that's greater than 3 millimeters in diameter. And then as we get more progressive fibrosis, it leads to liver cirrhosis. And your liver cirrhosis is characterized by fibrosis and nodule formation secondary to a chronic injury. And then this alters the normal lobular organization of the liver. Complications in this condition include your compensated cirrhosis, ascites again, varices again, hepatic encephalopathy, bacterial infections, retinopathy, and hepatocellular carcinoma. The third way hepatitis C affects the liver is the pathway that leads to liver cancer. So we know that the HCV replication impairs the cellular DNA damage responses. So it promotes that instability of the infected host cell genome, and it exerts a direct cancer promoting effect, as well as eliciting the immune mediated inflammation and apoptosis. So overall, we need to remember that it isn't beneficial for the HCV virus to cause cancer, because that means the host is going to die at the end of the line. So it's more beneficial for it to not affect the host in that kind of way. But the studies have found that it has to upregulate and downregulate certain oncogenes to allow for better reproduction. So it's a collateral damage almost. But it does it via direct and indirect ways. So the direct way is the HCV deregulates the host cell cycle checkpoints, and then plus the immune and virus mediated oxidative stress and DNA damage. So we have these infected cells that accumulate mutations, and then eventually is going to result in a transformation into a malignant cell. The indirect pathway is where we have the immune or virus-mediated apoptosis. So we have the compensatory proliferation, and then, of course, the reinfection occurring. As the cells get damaged, they repair and they get reinfected, or the new cells come. So the uninfected bystander cells, they also start accumulating these mutations, because there's now this environment of inflammation and oxidative stress that has been caused by the direct pathway as well. So we have the proliferation of the transformed hepatocytes. So a feature of HCV is it causes cell cycle arrest at the interface of G2 and mitosis. So both these ways then make the patient more susceptible to liver cancer. And this can also increase the risk of non-Hodgkin's lymphoma and head and neck cancers. But the most common cancer in the liver is the hepatocellular carcinoma that is caused by Hep C. So we've seen that the severity of liver fibrosis tightly correlates with the increased risk of HCC, and it's via those genetic aberrations which we talked about. And then, of course, in liver cancer, what kind of complications do we see? We have hepatic encephalopathy, we have portal vein thrombosis, worsening ascites, variceal bleeding, obstructive jaundice, and pyogenic liver abscess. And then another life-threatening complication of HCC is your intraperitoneal bleeding. All right, guys, so that is it for this mind map. I hope you enjoyed it. If you did, please like and subscribe and share my videos. And remember, leave me a comment if you want to have anything specific talked about. All right, and map you later.